And welcome to this evening's Maternity Midwifery Hour. Now it's session 12 of series 11, and welcome to everybody here. For those of you who are new, welcome. And for those of you who are our existing people that come every week, big welcome as well. So it's lovely that you're with us this evening. And I think you're going to find this evening's session really interesting. We're joined by Wendy Randall and Dr. Denise Tiran this evening. And we're going to be looking at kind of different approaches to pain relief and pain management in labour. But before we start, we're going to put them on the spot and ask them to share with us a moment of their week, something nice. So shall I start with Denise? Please share your moment of the week.
Thank you, Sue. Well, despite a lot of problems with the trains, I've had two very exciting and productive days. Yesterday, I was in Birmingham for a meeting of the Royal College of Midwives Fellows, and we were looking at developments and the work that the Royal College is doing. And then today I've been on a business workshop, so that's been quite exciting. And we had to talk about our successes in the last 3 months. And one of mine was that I had managed to clear my work diary sufficiently to take the first 3-week holiday I've had for 10 years. So
Wow.
I actually won a bottle of gin for that.
Gosh. So you've got a clear diary and a bottle of gin.
Yes.
Fantastic. Well done to you. That's a lovely moment to share. Thank you, Denise. How about Wendy? Do you have a moment you could share with us?
Nothing. I wish I had a bottle of gin. I don't have a bottle of gin. I think it's just, we had a really positive meeting this morning with our birth centre staff, which was really great, really brilliant to sort of hear how they're feeling. So I think we've done lots of listening with staff. So it's really brilliant hearing how people are feeling, how we can share things with them, and how we can, strive forwards to make, a better working environment and a great service for women. So these are always very positive meetings when you come out of them.
Fabulous. Thank you so much. Well, that's lovely. Those are two lovely moments because it's about looking after yourself and getting some sort of sanity in your own life, but also looking after others around you, which I know that you're both deeply into. So thank you for sharing your moments of the week so beautifully. Now I'm just going to do my usual, and this is really for the people who are joining us for the first time this evening. Really to just say where the maternity hour came from. And I guess it's very much at the front of my mind because at the moment in the UK, there's the COVID inquiry going on. And the maternity and midwifery hour was born in the first lockdown in the UK during COVID. And it was really a way, because we couldn't have study days, we couldn't have conferences, we couldn't have festivals, and it was very difficult for midwives and student midwives to have updating opportunities. We felt that we needed to put something on to really provide some information and some connection for midwives and student midwives, and we did. And in the initial sessions, we did a lot of stuff around COVID because that's what people needed at that time. We did a lot about how different maternity services were managing and what they were doing and the sort of things that would help them, sharing information out. And now we're doing more about sort of what you might call traditional midwifery stuff. But we do return to COVID and it's still around, and we need to remember that. So the important thing for this, and if you haven't ever joined any maternity midwifery forum things before, I have to say, everything is recorded within an inch of its life. So if you miss anything or you enjoy this so much this evening, which I hope you will, that you want to watch more and more, just go to Matflix, because Matflix archive and look after everything and all the recordings. And there's masses and masses of information. So if you're just interested, there's lots of information. If you're trying to do your revalidation as a midwife, loads of information which will help you. If you're a student midwife doing a project or a midwife doing some sort of work project or dissertation or anything like of that nature, there's lots of information there for you. And if you want something very targeted, you can have a look at subscribing to the box sets, which Dr. Jenny Hall looks after. And those are more sort of finessed things where you get a whole chunk of information, plus a few reflective activities and a few other little bits and pieces that she puts in the box sets. But otherwise, everything's free to use. And if you have an institution subscription, even better, because it's then free for individuals to use, which is fantastic. And we love you to share. So if you enjoy this evening, when you get your recording, share with your colleagues. Really good to have a discussion about things, especially if you find any, and some of you will find some of the information new, maybe a little bit challenging, thought-provoking, and you might want to discuss it with your colleagues. And this is a really good way of deepening your understanding of what we're going to be talking about. So do share. We love that. I'm going to also say, look after yourselves, because you're all working your socks off, I know, because that's the way midwives and student midwives have to operate and always do operate. So look after yourselves as you're looking after other people. Now, I'm just going to do a quick snippet on news. I know that the conflict in the Middle East is still going on, and it's a terrible, terrible time. And I'm just personally praying for peace, both sides, for this terrible violence and destruction going on, because of course the people that it hurts the most are the innocent people, the women, the children, and the men have nothing to do with anything. So we have to think of those people as much as we can. On to lighter things, we'll say Happy Independence Day for Finland. And also I've just been reading this thing on child poverty in the midst of wealth, which is quite interesting. It's from UNICEF and it's on your resources list. There's lots and lots of really tasty information on that resources list this evening, and this is one of them. It's the Innocenti report card 18. It makes very interesting reading. You can have the kind of edited highlights, the executive summary if you're busy, or if you're doing something in a project and disadvantaged women, for example, or children, then it's worth looking at the big report because that's much more in depth. Okay, so that's where it's at, and we're not doing so well in the UK, I have to say, which is concerning. So it's something we need to address. Okay, and there's also, I noticed on Twitter, and I'm not going to call it that other thing because I'm a Twitterer, not a whatever it is. There's been quite a lot of discussion about the rise in whooping cough. So if you're a little bit rusty on your vaccinations and what we should be saying to women and their families, and I know they are, a lot of times they ask us what we think. I know that there's a really good clip from a couple of our festivals on, right from the NHSA, on vaccination and what information we need and how we can address it with women and families. So have a look for that. I think it's gone out on circulation as well, so you may have already seen it, hopefully, and hopefully that will help. Okay, now I've raced through that, and I know, but this evening I want to move now into the main meat of the evening, which is looking at supporting women during labour. And we're having a little bit of an update into different strategies. And it's a really important part of our role to provide the evidence base. And this, you're going to get lots of evidence base this evening, lots of evidence-based information to women prior to labour and during labour. And remember, just because the woman chooses one thing doesn't mean she wants to carry on with it and on with it, on with it. And I know my colleagues will say the same thing. So we always need to be very sensitive and very intuitive with women and their families to make sure they're happy with what's happening. Now I'm going to start by introducing Wendy Randall, who many of you will know of, and she's going to be our first speaker. She's a dual registered nurse and midwife. She's also got a master's degree in public health and leadership, and in her capacity as midwife she's worked in all sorts of roles in primary and secondary care. And before she was a head of midwifery, which she is now, she was a consultant midwife for 10 years, including she had a secondment as the consultant midwife lead for the RCM in the Avoiding Brain Injury in Childbirth programme. And she's also as many of you will know, being recognised nationally for intelligent intermittent auscultation. Doesn't that sound lovely? Perfect. And its contribution to midwifery education and safety. She's passionate about the value of multi-professional team working and education to improve the safety and experience of women and families through their journey to parenthood. So, Wendy, welcome. Thank you so much for joining us this evening. And Wendy's going to be talking about sterile water injections during labour, which I think is a very interesting area. So thank you, Wendy. The screen is yours.
Thank you for the introduction. Let me just share my screen with you. Oh, I need to go all the way back. And if you saw that, you saw whistle stop tour before we began. So thank you for inviting me to talk this evening. I wanted to talk about sterile water injections for use for women with back pain and labour, because I was one of the leads for Site 15 of the Icarus trial. And Icarus stood for the impact on caesarean section rates following injections of sterile water. It was a CTIMP, which is a clinical trial of an investigational medicinal product. And it was a randomized, double-blind, placebo-controlled trial. The majority of sites were in Australia, and when I was working in Oxford, it was the only UK site. So it was a midwifery-led trial, which was incredibly exciting. They picked the topic of looking at impact on caesarean section rates because some of the smaller studies had suggested that there might be an impact on caesarean section rates. And we'll go into the findings from the trial afterwards, but it certainly enabled us to get funding for the trial, as well as looking at the secondary outcome, which was about the effects in terms of pain relief. So this is what NICE guidelines says just now, and I'm very proud to say that the trial that we were involved in actually influenced the change to NICE guidelines. So I think that's a really important thing for future midwives or midwives out there when you're doing research, is that you can have an impact and lead to national change. So NICE, prior to the findings of our research being published, used to say do not use. They referred to it as water papules. And now that this is their stance, and I will share a few of those as we go through this evening. And I think, you know, the biggest message use an alternative for them that would not affect their choices to go on to have other methods of pain relief if they won't. But it's a very cheap option and can be used in any birth setting. So it's quite an exciting thing for us to be able to offer to women. So what are sterile water injections for people that don't know? It's if anybody's given or seen a BCG, you are creating a bleb like a BCG on points in the back. And what happens is you inject sterile water just underneath the skin in 4 points in the back, and it causes an osmotic and mechanical irritation. There is significant pain associated with it, and that is really important that that is acknowledged, but it does pass incredibly quickly. And we'll talk about that when we get to the point of administering it. And what all the evidence is showing is that pain relief follows almost immediately and is there for up to 2 hours afterwards. So this is the kind of physiology behind it. So gate control theory of pain was quite a revolutionary pain theory. So I'm going to try and make a simple explanation of quite a complex process. So excuse me while my brain thinks, but it's a neurological gateway exists in a portion of the dorsal horn, I'm not going to be able to say it properly, called the substantia gelatinosa. And basically there's densely packed cells which remain open to normal and constant transmission of nerve impulses from peripheral fibers to cells of the spinal column. And essentially what happens is a gate that remains open to the normal and constant transmission of the nerve impulses from the alpha delta to the C nerve fibers. So that's a big explanation. But it's working on the gate control theory of pain. You're trying to shut off those messages from ultimately getting to the brain. And they also refer to this diffuse obnoxious inhibitory controls. This is LeBar. And basically, if you have two pains working together, but not in the same part of the body, the stronger weakens the other. And this is like my description of a sterile water injection. It's like a sharp shock. It shocks the system and the body goes out that pain and forgets the other pain that's been causing the compression of the nerves and the viscera, which has caused that intense referred pain that women experience in their back. And so when you think about women, oh, sorry, excuse me, going back. I'm just hoping your slide isn't blocked by my bit at the top of my, there we go, got rid of it. So in terms of back pain and labour, there's roughly about 30% of women experience intense back pain in labour, and that's known to be a referred pain. People have commonly felt that it was from an occipital posterior position. And actually, when you look at a lot of the trials, they've actually talked about, you know, is it actually that the baby is in an OP position, or is this baby a malposition? It's deflexed and it's unable to do that descent and rotation. And because it's pressing on those nerve endings, it's causing this quite intense pain, and the body responds to that by clutching the muscles, which basically holds that baby up and stops that baby from descending into the pelvis. It's more common in nulliparous women, and I think a feature of this back pain in labour is actually it tends to persist through the uterine resting phase, and obviously gets more intense when there's a contraction. And the reason we looked at caesarean section as one of our outcomes was because we all know that malposition, that lack of descent, you know, a deflexed baby's head is you're more intent to get like a labour dystocia. You have a longer labour, and obviously if you have increased pain, you're more likely to require something else to help you to cope. And that longer labour, then you're more likely to require intervention to help you progress in labour. So it was really important for us to think about how we could make a difference to that. And actually, within the research, we actually found that out of, you know, the women that we looked after, 40% of those women had a baby in an OP position, and it was the other 60% were between OA and OT, but obviously they were from a deflex position. So that's why you can't always, we always go, back pain, it must be OP. So what we want to do is change that thought process to say, actually, it's more likely due to a deflex baby's head. So this is the evidence. So this is the trial that I was talking to you about. It was, like I said, it was referred to as Icarus. And it was published in the Lancet, and this is what has led to the changes in national guidelines. And actually, it was what enabled us to bring it into our unit, because very much have been some units around the country who've introduced sterile water injections before, you know, the trial was published. But, you know, in organisations generally, we're promoting evidence-based practice. So it was very important to have that evidence, and it enabled, you know, a tertiary referral centre to say, OK, we have the evidence now, we have to promote this and push it forwards. And it was actually our research department that actually pushed forwards with changing the changes to national guidelines. So hopefully this is easy to access. You'll access that, and there's a reference list as well. So this is again from NICE guidelines. So it's about explaining to women that they can get almost immediate relief from that back pain, and it can last for hours afterwards. But it's interesting, their use of the words. It's an initial stinging sensation. When I describe this to women, and I've counselled women, obviously, for these injections, we gave a lot of them in the trial and then afterwards, it's painful. On a scale of 1 to 10, having that injection is about a 10, or it was for us. So it is a sharp shock. It makes you go, ow. But it literally lasts for 10 or 20 seconds, if that. And the art is, this woman is in intense pain anyway. If you looked after people with back pain in labour, you will know that they speak very much about, they feel like their back's going to break, that people are stamping on their back, that it's just intense anyway. And then when you add a contraction, it gets even worse. So what we do with the sterile water injections is we say, well, look, we're going to give you a pain, but we'll give it to you during your contraction. So when you're at that height of the pain, you'll have it. And then the injection is finished before the contraction is actually finished. And actually, it can immediately, and it can be literally like flipping a switch, turn off the back pain for that woman. So if the woman says, you know what, I don't fancy that, that sounds horrible, my pain is bad enough as it is, I don't want it, that's absolutely her choice. But if she thinks, well, do you know what, I hate this, I've had this for X amount of time, if there's a way that you can, if I have to just take one more contraction where it's really intense and there's the potential that that stops, for a large proportion of women, that is a good option for them to do. So I think that's one of the key things in terms of, it's really important that you tell women about that, because if you don't tell them about it, they won't believe you for anything else you tell them for the rest of that labour. So it is really important to be open and honest about it. So these are the results of our trial. So this is looking at the time of injections. And the reason there are these 50% and 30% is because in terms of when you're looking at research for pain relief, they talk about women having 30% relief from pain or a 50% relief from pain, is in terms of showing the efficacy of whatever method you're doing. Although it is really interesting to know they haven't used those same efficacy grades for things like pethidine in labour either, but they did use it for sterile water injections. And I think you can see hopefully quite clearly from that when you're comparing the sterile water to the placebo, which is saline, you can see that there is some benefit from the saline, but there is more than double benefit in terms of the women who have sterile water. And the explanation, I'm sorry, I haven't given you before, is why does saline actually work? Because saline will provide a brief stinging sensation. It very much does. It's not nearly the same in terms of pain threshold as sterile water, but because of the osmotic effect, saline just disperses and it doesn't keep the bleb that stays there with the sterile water. So it will provide some initial relief, but it won't go on to provide any prolonged effect. And this is what women say about the effectiveness. So, I think when you're looking at that, again, the difference, you've got double the women, or more than double the women, are saying it was very effective. There are obviously going to be some women that say it wasn't as effective. And there were some women, and if I can use an example of a woman in labour who she was somebody having a second and subsequent baby, and she came in and her labour was she was stuck. She'd been 4 centimeters, 4 centimeters, 4 centimeters, and she said, I've had it, I want to have an epidural. We talked to her about having the sterile water injections, and we called the anaesthetist because we weren't there to stop her from having it. They said, oh, I'll be down in about half an hour. She said, you have to do something now. This is just as it was. I can't cope any longer. So she went for the sterile water injections and we gave her them. And literally, I think we turned around to put the needles into the bin, and all of a sudden we had a baby. And certainly before the anaesthetist got down the corridor. And it was, from her perception of it, she didn't need that injection because she was going on to have her baby. But actually, was it that she was just going on to have her baby, or was it that it was the injections took the back pain away that enabled her to relax and birth her baby? And you'll never know which one it is. But that's why when we look at the comments in terms of people saying, I didn't think it was effective, it's because predominantly they birthed their baby really quickly. We also had a nulliparous woman who, again, I think she was stuck at 2 or 3 centimetres and really wanted to go into the birthing pool. And we said, well, look, you know, she'd horrible back pain. We said, look, do you want to have these injections first? We gave her the injections. And then by the 5 or 10 minutes later, when we're getting her into the pool, she put her leg over the side of the pool. And luckily the midwife caught the baby before it went into the pool. So, you know, we have lots of stories and experience around it. We have the data, and I'm absolutely showing you the data, but I wanted to share with you that it's really quite amazing when you use these sterile water injections. It certainly amazed me how quickly you can turn off that back pain in labour. So we asked the women, did they feel satisfied? And again, I think you can see that the majority of women did feel satisfied. And again, thinking, why wouldn't they feel satisfied? You know, again, did they see the link from the effect of that to them birthing their baby? And then, but would you have it again? And again, you've got a proportion, you know, more than half the women said, absolutely, I'd have it again. And some that were saying, no, didn't like the pain, wouldn't do it. And that's fine, because it's choice, isn't it? And it's really important that women have the choice. Would they recommend it to others? I mean, I think when you get, you know, almost 70% of women saying, yes, I would recommend it to others, then that's incredibly positive. And I should have said, in terms of the questionnaires for the pain scores afterwards, we had 70% of women responded. So out of the 1,166 women in the trial, 70% of them gave us their feedback on all of these questions that I'm sharing with you. So very important when you're talking to women, what are the advantages of sterile water injection? It doesn't have any effect on the woman, you know, in her level of consciousness. It doesn't cross to the placenta. It doesn't affect breastfeeding. It can be repeated. And like I said, you know, it very often enables them to continue in labour and birth their baby. In terms of the disadvantages, you have to tell them about the pain, like I said before. It is, at present, it's only limited to back pain and labour. I know that the Australians are looking to extend the trial to look at it for use in other aspects of labour, but just now our evidence base is all on back pain and labour. So if it's a woman that doesn't have intense back pain, it won't necessarily work for her. And with any pain relief, and this applies to your morphine, your pethidine, whatever, you know, there are a percentage of women that it doesn't, around 5% of women won't get pain relief from it. So now I'm just going to talk through how you actually give the sterile water injections, and I'm probably way over time, I'm very sorry. I'm going to speed talk this because you'll have the slides anyway. So we use 4 different points around the Michaelis rhombus. I've talked about the bleb. You have to find the right point to get your Michaelis rhombus. For some women, it's really clear, and you put 4 injections into her back. It's ideal to do it with 2 people, and you're doing it at the same time, so that you both say now and now, so that the woman isn't having to go through having 4 injections. This is the equipment that you need. So I think in all, it probably costs about 30 pence to give sterile water injections by the time you look at the cost of the sterile water and the syringes. And this is what it looks like on somebody's back. So you can see the blebs that occur, and the blebs should be about a 5 pence piece, and they're very superficial towards the skin. And then I'm very quickly going to show you what that looks like in practice. So you can see they're deliberately using a marker pen, and it looks like a permanent marker pen, but please don't use that on women. They don't need that kind of evidence that they've been in labour and had their babies. So, you know, they've identified their 4 points, and this was filmed in Australia. We used this as part of the training for the trial, and then you're going to see that they're basically going to go round about, and they do it together. So they're both looking at each other and saying, this is what we're going to do. And even when you see this result, you will see that the bleb on the right hand side at the top is much better than the one on the left. It's a bit closer to the top of the skin, and at this point, when you do put that injection in, she is going to yelp, and that is it. So I did have another brief slide summarising, but I have really overrun my time, and I do apologise to Denise for that. And happy to take questions later. But a lot of the information is in the research paper and in NICE guidelines.
Fantastic. Thank you so much, Wendy. That's very clear. And it leaves, I'm sure our audience will have lots of questions, and our audience always have good questions. So if you have a question for Wendy, just pop it into the chat box and it'll come through in the usual way. So thank you, Wendy. Gosh, that's a lot to think about. And having the little film is really good, because that makes it real, really, for those of you who are watching. So we'll move rapidly on to introducing Dr. Denise Tiran, who is an internationally renowned authority on midwifery complementary therapies. If you haven't read her books, you're missing out. She pioneered the subject as a midwifery specialism since the early 1980s. She's previously worked at the University of Greenwich, where, having trained in several therapies, she was given the opportunity to develop the UK's first practice-based BSc honours degree in complementary therapies. In 2004, she established her own company, Expectancy, wonderful website if anyone's interested as well, which provides a unique range of complementary therapy courses for midwives in the NHS and overseas, and a licensing system for midwives wanting to offer therapies in private practice. She's written loads of textbooks, including Complementary Therapies for Post-Dates Pregnancy, just out, on your reading list as well. And she's also revised the last 6 editions of the Balliers Midwives Dictionary. Very handy for you, all of you watching. She was awarded an honorary doctorate by the University of Greenwich in 2020 and a prestigious RCM fellowship in 2018 in recognition of all the work she's done. And she's also written 4 RCM position statements on complementary therapies, and earlier this year was commissioned by the RCM to write new guidelines for midwives using complementary therapies, due any day now, really. Yes, so welcome to Denise, and thank you so much for coming this evening. The screen is now yours.
Thank you, Sue. Thank you very much. And thank you for inviting me again to contribute. Thank you to Wendy for your session. I was fascinated, actually, because in fact, the points that are used for sterile water injections are actually very similar to the points that can be used for acupuncture for pain relief in labour. So it's not only based on the neurological pathways, but it's actually some points that relate to an energy line used in acupuncture that flows through the uterus and therefore contributes to reduction of pain in labour in that way. So they are very, very similar, but they're slightly different mechanisms, but it's the same sort of points. So thank you very much for asking me. And this time I've chosen to talk about safety of complementary therapies to a certain extent, because we are having a lot of national scrutiny at the moment. From a variety of sources, CQC, the Ockenden review teams, and parents' support groups that evolved from Morecambe Bay issues and this sort of thing. And there's been a lot of media coverage, public media coverage of how awful complementary therapies are. Now, I wouldn't have been working in this field for 40 years if I didn't think there was some benefit to it. And I think we have to start with looking at how valuable complementary therapies can be. By complementary therapies, we mean anything that is outside of mainstream healthcare, maternity care in our situation. and that can be used alongside it. And I don't talk about alternative therapies. I do definitely talk about complementary therapies, because certainly in maternity care, they should be used alongside any conventional midwifery or obstetric care and management that's included for individuals. So we're looking at things that may be supportive therapies, aspects like massage or aromatherapy, reflexology. We're looking at therapies which may address specific issues. So acupuncture, for example, can be very effective for nausea and vomiting in the first trimester, certainly for pain relief in labour. Clinical hypnosis. I'm not talking about hypnobirthing, because hypnobirthing isn't technically classified as a complementary therapy in the complementary therapy world. Of course, it is a complement to our care, but there's a fine differentiation there. But clinical hypnotherapy can be useful for dealing with those women who have tocophobia, fear of labour, or needle phobia, preparation for birth. And I think this is where we can start using the complementary therapies as midwives, but we also have to remember that a lot of parents will use elements of complementary therapy or perhaps natural remedies during their pregnancies. Indeed, some use natural remedies to help them get pregnant, especially if they've had difficulties in conceiving. But it can be quite difficult because we don't always know that parents are using various therapies, natural remedies. They may be self-administering aromatherapy oils at home, putting them in the bath or whatever. They may be deciding to try raspberry leaf tea to prepare for birth. They may be using ginger as a solution to their nausea and vomiting. And sometimes it isn't appropriate and sometimes it isn't safe. So I think we have to be able to help them. Now, I have long said that the Nursing and Midwifery Council in the UK should be encouraging training of pre-registration midwives and certainly post-registration midwives, not necessarily to get involved and to practice different therapies, but we ought to all be able to advise parents, ask them questions, or if they ask us questions, to answer them, because often the parents are doing these things and they're not telling us. Perhaps they don't feel we need to know. Maybe they think we'll be a bit skeptical or whatever. Actually, we do need to know. And especially when it comes to elements like aromatherapy, where we've got chemical, pharmacologically active oils, or when people are using natural remedies, so they're perhaps taking St. John's wort for as an alternative to antidepressants, and yet St. John's wort works exactly the same way as selective serotonin reuptake inhibitors, and therefore you can't take them together because you have a greater risk of side effects. So there's lots of things that I think parents are doing, but they're also wanting something to help them as they get to the third trimester. They're looking to prepare for birth, and they are perhaps bringing their own remedies in. And many of you may have been faced with parents who bring in oils, or they have homeopathic remedies which don't work the same as herbal ones, or they may occasionally be accompanied by a doula or a therapist who's doing some reflexology or something like that. There is no doubt that complementary therapies, when used properly, effectively, appropriately, can be an extremely good adjunct to the care that we're providing as midwives. So if you use them through certainly the last trimester of pregnancy, there is evidence to show that it will facilitate physiological birth at a very, very basic level. Most therapies are relaxing. And if you can reduce the stress hormones, the cortisol and what have you, then obviously you're going to help release of oxytocin, because cortisol suppresses oxytocin. You're going to enable parents to cope better with the discomforts that they do have. And we can use these different therapies and remedies either before labour or even to aid the onset and progress of labour, and then during the first stage of labour as well. And in so doing, then hopefully we're going to have an impact on reducing these huge, horrendous, in my opinion, levels of intervention which we've currently got in many units. I'm working with a maternity unit at the moment where they have a 60% induction of labour rate. And, you know, the midwives are horrified by it, and they just don't know how best to tackle it. So we're looking at bringing in aromatherapy, we're looking at setting up a post-dates pregnancy clinic using acupressure, and a variety of other things. So it's really useful in reducing intervention, and there is evidence to show that too, both in the UK and in some overseas countries. I think also it's about enabling midwives to get back to that nurturing that is fundamentally a part of midwifery. And that helps to improve parents' experiences of birth. It makes them feel that they've had a more satisfying experience, even if occasionally things do go a little off the normality spectrum. They can cope with it better because they feel nurtured and cared for. And at a managerial level, there is evidence to show a real cost saving if you can reduce that cascade of intervention. And if you look at the cost of a cesarean, which I think is somewhere around £7,000 or something now, Wendy might be able to correct me on that. But, you know, if you can encourage a more spontaneous vaginal birth, then not only is that better in the long term for the woman, but it's also a great deal better for the institution, the unit. And by doing that and improving parent satisfaction, you've then potentially got a reduction in the risk of litigation, where small things might have gone wrong. I'm not talking about the major complications, but small things might have gone wrong, and parents look for ways to get apologies and things like that. So there really are some benefits. However, we have to set what we're doing as midwives in the context of the place in which we work. And if you're in the UK, then obviously we have a great deal of rules and regulations and directives which we have to follow. I have to say, NICE, the National Institute for Health and Care Excellence, is not particularly enamoured of complementary therapies across the board, not just in maternity care. But as you probably know, the intrapartum guideline was revised and was published in, I think, September of this year. They haven't changed a great deal from the last one when it comes to mentioning complementary therapies. And they say, well, you know, it's okay. They can have breathing exercises. They can have immersion in water, in a pool. They can have massage. Strangely, they say we should support parents' wishes. If the woman wants to have massage that's been taught to her companion, but they say we're not supposed to be offering it. Now, that doesn't actually make much sense, because either massage is safe or it isn't. And if it's safe, it probably doesn't matter who does it. They're also saying we shouldn't be offering or advising aromatherapy, yoga, acupressure, either in the latent phase of labour or in the established first stage, and they go on to look at acupuncture, acupressure and hypnosis. But the problem that NICE has is that they don't know where the evidence is. So they tend to say, well, there's no evidence, or there's very little evidence, or it's not very robust evidence, because randomized controlled trial methodology does not fit with complementary therapies, where by definition it should be holistic for the individual, and it should be individualized according to what they want and need, and it's appropriate for them. So we've got a real problem when it comes to research, and it's easy for people to say there's no evidence. There is, but it's a bit difficult to find. And then, as I said earlier, we have issues particularly around aromatherapy. There have been a couple of cases in units which are being investigated by the Ockenden teams. And I'm not here saying anything that is outside of the public domain. There have been some inquiries about midwives not getting medical support because they've been wondering about using aromatherapy and this sort of thing. And, you know, it's alleged, but it really sort of undermines what people are doing when they're using complementary therapies in their own practice. If we're using them, we have to make sure not only that we use aromatherapy or any other therapy in conjunction with our midwifery regulation. So in the UK, that's the NMC code, the standards for practice. We obviously need to have indemnity insurance, we know that. And when it's something like aromatherapy, it has to be in line with medicines management principles. They are not medicines, but they act like medicines. So they're full of chemicals, the oils, but you still have to use the same sort of principle. We also have to set our therapies in the context of the organisation in which we work. So with things like acupuncture and essential oils, anything that we are physically doing has to fit in with health and safety regulations. For oils, it's controls that the control of substances hazardous to health, and even after Brexit, something called the cosmetics regulations, which sounds a bit odd because they're not cosmetics, but there's nowhere else to put essential oils. So some of the regulation of aromatherapy comes under the cosmetics regulations. Now, I think one of the issues that is occurring is that midwives who practice around complementary therapies, whatever it might be, reflexology or anything else, tend to get very, very enthusiastic, and that's fantastic. We want them to be enthusiastic, those who wish to be involved in using their therapies. But you have to recognise when it's appropriate and when it's not. And basically, parents who can have complementary therapies, either in pregnancy or in labour, will be those who have obviously given informed consent, but those who have no medical or obstetric contraindications, conditions. It is not appropriate at all to be using any complementary therapies for women who have complications from pre-existing medical conditions or from obstetric conditions. And that is where some of the concern in the public eye has come from. On the whole, if you look at saying, well, those women who are eligible for a birth centre birth or a home birth are the ones who may be eligible to receive complementary therapies. Has to be obviously in conjunction with whatever else is being done, and the NMC code says that your therapies have to be compatible with any other care. But you have to really eliminate those people who are not eligible to use complementary therapies at all. So depending a little bit on the individual therapy, it would not be appropriate to use aromatherapy oils on the antenatal ward or the triage area, because by definition, some of those women will have potential complications. I've put main delivery suite in brackets here because, of course, occasionally we may have women who would have had a birth centre birth, but maybe the birth centre has been closed for whatever reason. And so we're still looking at parents whose medical and obstetric conditions are within normal physiological parameters. There are definitely some medical conditions which totally preclude the use of any of the complementary therapies, really. But then, you know, sometimes you're looking at liver disease. If somebody has liver disease or obstetric cholestasis, they wouldn't be eligible to receive aromatherapy because the oils are metabolized via the liver. But they may also not be eligible to receive reflexology because it is possible to overstimulate the liver by working on specific foot points that correspond to the liver zones. With acupuncture, you can't use acupuncture for anybody who is on anticoagulants. And that causes us a bit of an issue because so many women are on prophylactic aspirin or enoxaparin. And yet, because you are inserting a needle, which is invasive, you have to be extremely cautious. You need to be cautious with therapies like aromatherapy oils, which will affect everybody in the room, because the babies would not be eligible to inhale those vapors. If you can smell the vapors, the aromatic vapors, you are actually inhaling the chemicals. You have to be careful. And I think the watchword has to be, if in doubt, leave it out, is my motto. If in doubt, don't use anything until you've maybe checked it. Or if you have any reason to be concerned, whether it's intuitive or after an assessment, then it may not be appropriate for some people to receive those therapies. It does depend a little bit on the individual therapies, but as a general rule, you would only want to work with those who are within physiological parameters. So what do you need to know if you want to be involved in either using complementary therapies, especially the manual ones, in your own practice, or if you don't want to be involved or you're not in a position to be practicing a therapy particularly, then what advice might you need to, what information might you need in order to advise parents appropriately and safely? Obviously, you need to know who can have the therapy and who can't, and for whatever reason. You need to understand how it works and how you use it. So that will be the actual practice of each therapy. For example, there are some acupuncture points which, if you put the needles in at the wrong angle, can cause complications. So you'd have to know what you were doing, and you'd have to have understood the underpinning theory of the therapy before practicing it. And of course, you have to do it within the guidelines. You've got to have clinical guidelines that are ratified and updated regularly, so that the trust, if you're working in the NHS, will then cover you by its vicarious liability to do that. What we don't want is a maverick but very enthusiastic midwife doing her own thing. And I'm afraid we do get that a little bit with reflexology, where it's very easy just to tweak a little toe or something and think you're doing perhaps something to manage a retained placenta. But if you haven't got a guideline to follow you, and support you, you haven't actually got the support of your managers and protection under the guidelines. So it's really important to get that right before you carry on with what you want to do. Like any other intervention, you need to understand what happens if you don't use it appropriately, what relatively normal, in inverted commas, side effects might be, and what complications there are, and how to minimize those risks, but also how to recognize whether it's a complication of the therapy or something else going on with the pregnancy or the labor. I think it's important also to be able to advise parents accordingly. So raspberry leaf tea is probably one of the most common questions that parents ask, or one of the most common remedies that they use. And sometimes midwives can advise. Sometimes they give a little bit of information that's not wrong, but it's slightly wrong by omission. They haven't given complete information. And I think that's quite important too. And this is what I think the sort of thing that should be included in pre-registration midwifery. So you have to understand how to apply the principles of the therapy to your practice within midwifery, whether it's pregnancy or birth care, and how the use of that therapy by midwives fits into the institution in which you're working. And of course, then there's the evidence base. Yes, I've said that it's a bit variable, but there is some evidence there. It's not always good. I have to say that. It's not always good, but there is evidence there to support you if you know where to look for it. So that's a brief run through. And I mean, it is a vast subject. Complementary therapies is not just one thing. It's lots of different therapies. And your interest may focus on one particular therapy, but I do also think that midwives need an understanding, a question and answer type of understanding, so they can advise parents as and when they might ask you any questions. Thank you, Sue.
I was just thinking, Denise, I think if I was pottering about the ward with my aromatherapy hat on, I'd want you in my pocket. Just giving me a little warning, because it's quite interesting, because I think when you don't know a lot about something like aromatherapy, you can think it's very natural and very lovely, but it's very useful to know that it's got those, well, we're using chemicals. So,
yeah, I think aromatherapy is one of the most difficult, because it's nice.
Yes.
But actually we have to sort of look beyond the niceness and make sure that we're doing it safely and appropriately.
I think that's a lovely quote. Any of you who are doing an essay on aromatherapy, that's a perfect quote. Thank you so much for that. Now, we've got a lot of questions, and we'll just try and squeeze some questions. And the first ones are coming through now, I think. And I'm not sure if this is possibly for Denise and Wendy, and it's Emiliana Hall. Hi, Emiliana, who's saying, can they be used at home? And I'm not sure if that's the injections of sterile water or aromatherapy. So maybe we'll start with aromatherapy, because I've got plenty for Wendy after this as well.
Okay. Yes, absolutely. You can certainly use different complementary therapies in the home setting, and very effectively, and it often will make the difference between keeping the parents at home or maybe having to transfer them, because although we're not going to use the therapies to treat complications, often they will prevent or reduce the severity of some of the changes that could lead to complications. One of the things I'd say about using aromatherapy in the home is it still affects everybody, including if you have elderly relatives present, they may have medical conditions which are, contraindications. Small children shouldn't be exposed to a lot of the aromatherapy oils, and even pets. So cats lack an enzyme that means they can't metabolize essential oils. Dogs can't metabolize some specific ones like tea tree and eucalyptus. And I once had a midwife on a course who said her vet had told her that her pet iguana should not be exposed to essential oils.
Gosh, well that really gives you the holistic feel of what we have to think about, because it's not just the woman and the baby, it's the whole family in the home. So thank you for that, Denise. Okay, I've got a comment from Angela McHale, and thank you for that, Angela, who says, I used SWI for many years in Australia, Brisbane, and worked very closely with Nigel Lee. I've seen firsthand the awesome pain relief it provides. Unfortunately, back in the UK, I've not been able to take this knowledge forward in my health board. So thank you for that, Angela. Okay. And Joanne, hi Joanne, says, if repeated, I think this is about SWI, if repeated, how long is it recommended to wait? So that's a Wendy question.
There's not any definitive time in terms of how long you have to wait. It really is up to the women. And if you think that the majority of women are still having relief from that for a good sort of, for at least 30 to 60 minutes, if she then decides that she wants another, then you can give it. And the beauty of it is you can give it as often as you want. What you tend to find is that they don't often want it repeated more than 2 or 3 times at max.
It's sore.
It is sore. Yeah. And if the question was about sterile water injections at home, you absolutely can use it at home. When we talk about ideally, it should be, 2 practitioners will enable you to get 4 blebs, but you can do it on your you could do it if you were just a midwife at home on your own, because you could just work your way around the blebs. She might not let you do 4. Because she's feeling 1, 2, 3, 4 in terms of pain, but that's okay, because even 2 is helpful.
Okay, well I was just about to say, is it okay? Could you work just with 2 blebs? So that's really helpful. Thank you, Wendy. That's grand. Okay, and then we've got Sarah Abigail. Hi, Sarah, who says, sorry, I joined late. You're going to have to catch up, Sarah. So I do apologise if it was covered. How do you train staff to administer the sterile water injections, and how did you evidence that? And secondly, do you have a guideline? And she'd like you to share it if possible. I think I have to send some of this to you a bit later.
Yes, so I was contacted by some people on social media platforms and asked to share stuff. I'm more than happy to share everything that I use to help implement it in a trust. And it has everything in it. It's got a competency document as well. So like all of it is there for open use.
Okay.
So I'm more than happy to share that on.
Fabulous, thank you. This is all very sharing, wonderful. Thank you. And now we've got. Now this is an interesting question from Nicole Renison to say, is there any work being carried out with these injections for pelvic pain in pregnancy?
Not that I'm aware of.
Okay.
Not that I'm aware of. But yeah, sterile water injections have been used in pain management by pain practitioners before it got to the point of using it in maternity.
Okay, so you might have to look around for that.
Can I just come in there,
yes,
Suze? Sorry to interrupt you. But actually, I can say that there is work on using acupuncture for back pain, sciatica, pelvic girdle pain, that sort of thing in pregnancy. In fact, Amanda Redford, who is one of the lecturers in my team, she was a research midwife in the NHS until she left, but she was part of what's called the Ease Back study. EASE, Ease Back study, and they used acupuncture very effectively for pelvic girdle pain and that sort of thing. So there is quite a bit actually.
So this is why you're together. This acupuncture and injections go very well together here. Thank you. That's fabulous. Okay, I've got from Jo, who's at Ames. Hi, Jo. How are you? And she says, now this is lovely. This is a pat on the back for both of you. What a privilege to sit in on this wonderful masterclass. Thank you, Wendy. And I know to Denise as well. And I know, and this is particularly in the injections, I know there's been some controversy around on Twitter. Do you want to comment on that? And also, are there any downsides to shutting off pain signals in the way described? And that probably is for both of you, actually, but the controversy is one for you, Wendy.
Yeah, the controversy is for me. I haven't responded on Twitter to the negativity. I feel that the study speaks for itself. It is, when you're looking at evidence base, it's a double-blind, randomized, controlled placebo trial. So it's your gold standard in terms of evidence base, and it was, the intention was to recruit 1,800, well, I can't remember, but around 1,800 women to look at the effects of caesarean section, the impact on caesarean section rates, but actually in the end, due to recruitment issues and the time that it went on, we actually recruited 1,166 women, but that is absolutely enough to show the benefits in terms of pain relief. And I think there is, unfortunately, a lot of negativity about midwifery out there, which I think is something that we have to acknowledge. And I think the perception is that we're making women have this and denying them other methods of pain relief. And that's what I wanted to say as part of the presentation. This isn't about it. It is, as they say, it's complementary to what else is happening in labour. It's another option for women. And not every woman wants an epidural. And like I said, we used it in a trust where I worked before when there was a delay in getting an epidural. Now, that woman would still have got an epidural. We didn't deny her that. We weren't trying to manage her. We weren't going down a normal pathway. It was very much we were responding to what she wanted. She had pain. We had various options, and none of these women were denied an option to have something else. So it's very much an extra tool in the toolkit for a midwife in terms of the things that she can suggest to help a woman in labour, and then it's up to the women to make that choice. Having watched other things happen on on social media platforms before. I don't think anything is ever achieved by trying to dispel those myths. These people have their opinion, and their opinions are very strong, and which is why I just posted the evidence. I posted the evidence speaks for itself. And if you understand and can interpret research, then it's very clear that this has benefit.
So do go and have a look. For those who are watching, do go and have a look at the evidence paper that's on the resources list, because I think when you have this sort of nastiness that goes on, it's often because people don't understand it. They hear something like water injections for women in labour and think, oh, someone's trying to trick these poor women. And the reality is very different. I think Wendy's expressed it so well. If you have that, you can share this information, but also have a look at the proper evidence as is on paper with all the numbers. Good practice for those who are getting used to understanding the P number as well.
Yes.
Denise.
I would echo entirely what Wendy said, and I think that, as you said, Wendy, there's a lot of negativity. Some of it is very aggressive, and there is a huge backlash against physiological birth. But if we don't start looking at returning to physiological birth, I think the midwifery profession will change out of all recognition. And what that is doing for parents, I don't know. I do feel really sad at the moment about what's happening in midwifery. And yet we have these alternative options, which are not used outside of midwifery. They can be used within midwifery, as Wendy says, as additional tools, alternative options where it's appropriate. And sometimes those options will avoid the need for further intervention. So I completely echo what you're saying there.
And really important for us to know about. Okay, now we've got several questions, and I'm just going to do a couple more. And we have something from Jenny Hall. Hi, Jenny, who says, Denise, what advice do you give to midwives around their own health and aromatherapy reactions? Nice one, Jenny.
Oh, hi, Jenny. Yes, absolutely. Very pertinent question. One of the big issues that we face is a lack of understanding that aromatherapy, more than any other therapy, affects everybody in the room. If you think about the Entonox issues that we've had, where we've discovered that overexposure to Entonox, where you've got leaking cylinders, could contribute to issues for staff. It's exactly the same, but possibly worse, because a lot of that the sort of safety issues go unrecognized. And certainly I would say that midwives who are trying to get pregnant, having infertility treatment, and if they're in the early part of their own pregnancy, they certainly need to be extremely cautious. They may not be able to use oils in labour, such as clary sage or jasmine, which are thought to aid contractions. So if they're in first or second trimester, they should not be using those. And I think it goes beyond that to any member of staff. It could be the porters coming in or the domestic staff. Some will have adverse reactions respiratory wise. If it's got asthma, it might provoke an asthma attack. I myself have become increasingly allergic to geranium and rose. They share many chemicals. And what happens is, as you inhale the aromas, it aggravates your nasal smell receptors. And that then can have, quite a significant effect, might cause closing up of your throat and this sort of thing. So I absolutely think there is that clause in the NMC code that says make sure that you take account of your own well-being as well as that of other people. So that's a really strong one with me, and particularly with aromatherapy. It applies to some of the others too, but mainly aromatherapy.
Fabulous, thank you for that, Denise. Now we've got another Ali Kelly is saying I'm doing my dissertation on aromatherapy to reduce the transfer rate. This has been amazingly helpful. good
Thank
luck with
you.
doing that as that
Yes, good
dissertation.
luck for that.
And then we have now we're going to close. We have to close. I could listen to both of you forever because it's so interesting with all that. There's so much controversy and other things that we have to think about. But I'm going to finish with Emiliana again, and who said evidence-based options are always a good thing. It's then up to parents to make the choices as long as they've got the information for them. Thank you so much for sharing all of these additional options, and thank you indeed. It's been a fantastic session. For those of you watching, I hope you can share what you've learned and also share the resources because they're incredibly useful, all of them, from the nice documents to the aromatherapy ones to the RCT ones, also lots of information. And of course, the pain gate mechanism, which Wendy expressed so well, because that is really complicated. So thank you for that, Wendy. Now, I'm going to say a big thanks to Denise and Wendy. Also, I'm going to thank Angelo, who's behind the scenes, making sure everything's going to be beautifully recorded and kept so you can access it after this date. And for those of you who are up at 6 o'clock in the morning on Friday, we'll get your podcast for that. Also, thank you to Paul, who's been throwing the questions through to me, and I should have said that's why I keep looking away. I'm not looking away from you, but it's getting the questions through. And so resources will be available on the website and on Facebook. And just to say to you, everyone, take care of yourselves, stay well and safe. We'll see you next week. We're having a little bit of a Christmas selection box. Get the Christmas tree. So we'll see you next week and take care.